We'll be starting in a minute. Okay, I think we should get started. I'd like to welcome everybody to this program on how the pandemic has changed healthcare. This is the fourth in our series of programs. We wanted to discuss, as we did last year, how the pandemic has impacted things. While it's clearly a terrible, awful, obviously, event, the COVID-19 pandemic, and it has stirred things up in the healthcare and public health area. Has changed things. And in some cases, there were lessons learned, changes made, improvements occurred. And so this is what we're trying to explore here. Thought I should mention this is being recorded, so it'll be available if you want to share it with others. We'll send you a link. And other organizations use this recording as it's a pretty good background on the topic. I'm David Belson. I'm the program director of a new program we have on health systems management engineering. I'm in the engineering school, but our program includes the Keck Medical School, the Gare Center, who's operating this program. I'm in the engineering school. Also, the Price School of Public Policy is also a sponsor of our program. So I've been working in performance improvement area and teaching at USC for longer than I care to admit. So if you want to advance the next slide. So today we have actually four people speaking on this topic. Do we have a slide on the previous sessions? The three previous sessions, we covered different topics on the impact of the pandemic. The first session was on the impact on supply chain and how supply chains were dramatically affected. And I had, I think, an interesting program with speakers from the VA, from several different healthcare systems on the supply chain, from Cedars-Sinai, from Sutter, from kind of global health impacts of the supply chain. It clearly was disrupted, but in some ways now it works differently, in some ways better. So we had a program on supply chain. It's also in the recordings. Then we had a program on telemedicine. Clearly, telemedicine was dramatically impacted and the usage grew dramatically. And so we heard about how different healthcare systems adjusted and developed new tools to provide for healthcare online and digitally. We heard from the VA, from LA County, from a variety of different healthcare systems on how they've implemented, some cases more successfully than others, but implemented telemedicine. And then we had a session on staffing. Staffing has become a really critical issue in terms of retaining staff and recruiting staff and combating turnover. And so we heard from several different healthcare systems on what they're doing now to retain staff and motivate staff. And that's certainly been an impact of the pandemic on staffing. Our session today, the fourth in this series, we wanted to explore the topic of how the pandemic changed the public health system. It certainly impacted it, as it says here, presenting challenges that haven't been seen in generations. So our speaker is going to talk about the problems that were faced, the experience of the pandemic, hopefully what's going to work better in the future. And so we have actually four speakers here today who have very, very impressive backgrounds and experience, do teaching and research in the area of public health. The four are, who will speak first is Dr. Paul Simon, who's Chief Science Officer at LA County. Then we have Dr. Klausner, who's at USC, and a professor in Public Health. Next, Howard Hugh, who's also from USC in Population and Public Health. And then finally, Dr. Watanabe, who is also a professor of medicine. And I'll give a little bit more background before each speaker. So it'll be more efficient to do that way rather than going through their lengthy resumes. Alyssa, you want to talk about the CME process?
I'll drop the link in the chat in just a minute, but just make sure you fill out the form by 3 p.m. today, Pacific Standard Time. If you have any issues, just send me an email. My email's right there, and we'll put this up again before the end of the session.
Yeah, so you have to submit your information today, so be aware of that. Okay, next slide. We have rather than using the chat mode, we have a Q&A option down at the bottom of your screen. So if you have questions, we'll try to get some as the program progresses and also at the end. So if you have any particular questions you'd like to ask these people, please submit it in the Q&A box at the bottom of your screen. So our first speaker is Dr. Paul Simon. As it says here, he's the Chief Science Officer at the LA County Department of Public Health, and certainly a big responsible position in a very large community. He's also an adjunct professor of epidemiology at the UCLA Fielding School of Public Health. We won't hold it against him that he's at UCLA. Dr. Simon got his MD from the University of Michigan, his MPH in epidemiology from the Fielding School at UCLA. He's completed research and fellowships at a variety of different organizations, including the CDC. He was involved as a medical epidemiologist in the Division of HIV and AIDS at the CDC, and he was Director of Health Assessment and Epidemiology as well. So Dr. Simon is a board-certified physician in pediatrics and preventive medicine, and so let's hear from Dr. Paul Simon.
Thank you, Dr. Belson. And I'm going to just load my presentation here. Hoping everybody can see that.
Yep, all good.
Great. All right. Well, thank you for the invitation. Always appreciate the opportunity to talk about COVID. I think it's probably an understatement to say it's had a profound impact on public health, just as it's had a profound impact on virtually all areas of our lives. So I'm going to provide a perspective that's specific to LA County. I say here it's a local health department perspective, but just in full transparency, it's really my perspective. It's not an official health department perspective, but I think much of what I will say was very much in line with how our department has operated during the pandemic. And given that this is CME, I have included the obligatory slide regarding conflict of interest disclosures, and I have no conflicts to disclose. So I'm going to basically divide my presentation into 3 areas. Number 1, I'm going to talk about the pandemic's impact on population health in the county. Then I'll talk about how the pandemic has impacted public health practice, talking about some of the challenges, ways we've adapted, and in some cases, the pandemic has given us opportunities to really advance our efforts and I think our capacities really to hopefully handle other public health challenges as they present themselves in the future. And then the third area will be just some reflections on future directions, and then happy to answer questions or participate in any discussion. So let's talk about population impacts first. So there is a lot of chatter about how much COVID has really contributed to mortality across the nation and here in Los Angeles County. And some expressing concerns that our death certificate data may not be all that accurate in the ways that it classifies causes of death. So one analysis that we did, and it's presented here on the slide, is to look at all causes of mortality. So we didn't distinguish between COVID and others. We just took the raw numbers, and we know that the death certificate filing is very complete. Virtually all deaths that occur in a jurisdiction have a death certificate filed. And so we calculate rates of death. And in this slide, we're showing rates of death across the 4 largest race and ethnic groups in the county. And we're looking at the period 2011 to 2021. You can see in the brown line, the highest line, that's the all-cause mortality rate among Blacks or African Americans in the county. And these, I should mention, are age adjusted. The blue line is the white population, the green line, the Latino population, the orange line, the Asian population. And just for reference, our first case of COVID was reported in LA County in January of 2020. Our first death was reported in March of 2020. So prior to 2020, there really was no COVID, at least that we're aware of. And you can see from 2011 to 2019, our mortality was relatively stable. We had very, very large disparities that are longstanding, that we've worked very hard to try to reduce. But as this slide would suggest, we have not been very successful in reducing these disparities. Some folks are surprised to see that again, prior to the pandemic, that blue line, the white population, is higher than the green line, the Latino population. In fact, many, I think, assume that the mortality would be higher in the Latino population because in many ways they are disadvantaged in ways that adversely impact health. For example, they're much more likely to live in poverty, less access to health care, but nonetheless, they have a lower mortality than the white population. And that actually has been well reported in the literature, not just in LA County, but across the Southwest United States and even other parts of the country now. And it's been referred to as the Latino mortality paradox. And so what you see in 2020 is that with the now emergence of the pandemic, mortality in all groups went up quite dramatically, overall about 25% increase. So prior to 2020, we had somewhere around 60 to 65,000 deaths a year. And in 2020, that jumped up to about 80, I think it was about 83 or 84,000. And you can see that the increases across the different groups were not equal. The largest increase proportionally was in this Latino population. It was about a 40% increase. And in fact, with the emergence of the pandemic, this so-called Latino mortality paradox was obliterated. Now, beginning in 2020, the Latino population had a higher mortality rate than the white population and much higher than the Asian population. The African American population also had quite a large percentage increase, about a 30% increase. The Asian population, about a 30% proportional increase. The white population, about 11% proportional increase. And then from 2020 to 2021, there was a decrease in 3 of the 4 groups, but not back to baseline. Still quite a bit higher than 2019, but a decrease nonetheless, except in the Latino population where there was a further increase in mortality. So the bottom line, very, very significant impact on overall mortality with some clear disparities in the county. So now, when we do dig into the causes of death, and these are specifically the underlying causes of death, so these aren't causes that may have just been a minor contributor. These were listed as the underlying cause of death on the death certificate. Virtually every year for the last several decades, coronary heart disease has led the list by far. And you can see in 2019, before the pandemic, the second leading cause was Alzheimer's disease, quite a bit lower than coronary heart disease. And then you can see on down the list, the 10 leading causes. Although on this slide, we've ranked them based on the 2020 ranking from highest to the 10th highest. And so it's pretty clear here that COVID-19 has been a pretty significant cause. It rapidly, just in the first year of the pandemic, became the second leading cause of death, quite close to coronary heart disease, quite a bit higher than Alzheimer's disease. I think of note further down the list, and I'll talk more about this later, drug overdose deaths also increased substantially, a 63% increase. In fact, prior to 2020, drug overdose was not even among the top 10 causes of death, but then it moved into that top 10 group because of the big increase. We saw other increases that were a deviation from the prior decade. So for example, heart disease from 2010 to 2019, it decreased by about 30%, heart disease mortality. But during the first year of the pandemic, it increased by 9%, diabetes increased by 16%. Most of these actually showing increases, whereas prior to 2020, for many conditions, there were decreases in mortality. And we also look at premature mortality. So this measure counts not only the number of deaths, but for a given death, the number of years, the age at which the death occurred. So for example, if someone died at the age of 40 years, if they died at the age of 45 years, they would contribute 30 years of, quote, of potential life lost. So it's factoring in not just the numbers of deaths, but the ages at which people die. And in 2019, third on the list there, coronary heart disease was the leading cause of premature death, followed by drug overdose. But in 2020, COVID-19 emerged as the leading cause of premature death in the county, followed by drug overdose. And again, here a big increase, 65% increase. There are some other causes here on the list that were not seen on the leading causes of death list, because again, premature death is factoring in not just the number of deaths, but also the ages at which people die. So homicide, for example, which occurs more often among younger people, is the fifth leading cause of premature death, and it increased 30% between 2019 and 2020. Motor vehicle crash injuries, again, not a leading cause of death, but when you factor in premature mortality, it becomes an important cause of premature death. And here a 15% increase, which some may wonder about, given that almost everybody was off the streets. If you remember, we had really closed everything up in much of 2020. And for those of you who live in Los Angeles County, you may remember the freeways were wide open, no congestion. But during that time, because of the lack of congestion, people could drive at much higher speeds. And as a result, we sort of paradoxically saw a rise in motor vehicle crash mortality and premature mortality. Surprisingly, we did not see an increase in suicide mortality or premature mortality. And that is sort of counterintuitive, because we certainly heard many anecdotal reports of all the mental health suffering as a result of the stress associated with the pandemic. But in addition, I think the stress also associated with some of the pandemic response measures that were taken, leading to greater social isolation. We do know that there, and I'll talk more about this, there was significant mental health impacts, adverse impacts, not mortality, but certainly morbidity. Our sister Department of Mental Health, for example, described a great increase in the call volume on their helpline. And we did see big disparities by socioeconomic status. This shows the cumulative mortality rates for COVID broken out by neighborhood. On the far right, we've grouped neighborhoods where at least 30% of the population is living in poverty. On the far left, we group neighborhoods with less than 10% of the population living in poverty. And then you can see the two intermediate levels of poverty. And there is this, very steep gradient, with mortality in the high poverty neighborhoods 3 times higher than the mortality in the lowest poverty neighborhoods. And I don't think this is a surprise. It really reflects, I think, an exacerbation of what were already very disturbing existing disparities. Many would call them inequities in morbidity and mortality that we see across the county. Now, I did want to include more recent statistics, though, because it has been, I think, noted widely that we're seeing a very different sort of illness now with COVID than we did early on for several reasons. People seem to be less sick with COVID now because much more of the population is vaccinated. They have some protection through vaccination, but in addition, many folks have had past infection, which provides natural immunity. And then there's some evidence that the Omicron variant, the currently circulating variant may be less virulent than the variants that were circulating earlier. But despite this, I wanted to include these numbers because it does indicate that mortality continues to be pretty significant here in LA County, even with this circulating Omicron variant, just given the very high number of cases we've seen across the county during this period. So nearly 5,000 deaths in LA County overall. The vast majority in older age groups, particularly the 80 and older age group, but for younger adults and children, these groups are not completely unscathed. About 25% of the deaths, for example, occurred among adults under age 65. I was surprised to see that 6 of the 11 pediatric deaths we've seen in the county since the beginning of the pandemic actually occurred during these last 7 months. And then just some of the other demographic characteristics for these deaths that have occurred over the last 7 months. And I just want to note that the mortality rate on the far right here among males is double the rate among females. And this has been a pattern we've seen since the beginning of the pandemic, even though the case rates are pretty similar between these two groups. Mortality is much higher among males. And then consistent with what we've seen earlier in the pandemic, the mortality rate's highest among African Americans and Latinos, much lower among the white and the Asian populations. Also reported deaths in the smaller American Indian, Alaska Native population, Native Hawaiian, Pacific Islander population. We didn't include the rates because they're unstable. We don't present rates when we have less than 20 cases in a particular group, but nonetheless, I think significant mortality in these two groups as well. So I want to move on to morbidity impacts, and I think there have been important direct and indirect impacts. Directly, I think so-called long COVID or post-acute COVID, very significant. I think Dr. Hu is going to talk more about that, but I think it represents a real challenge for our systems of care, and I think an important source of ongoing morbidity. The mental health impacts, despite the fact that we didn't see a rise in suicide rates, I think they're now, I've not seen any local studies, but I've seen plenty of national studies that suggest that the mental health impacts have been substantial, both in adults and children. Both intentional and unintentional injuries. So on the intentional side, violence seems to have risen. And I mentioned, the motor vehicle related deaths and non-fatal injuries, also important. We've seen, though, impacts in other chronic non-infectious diseases. As I mentioned, a rise in heart disease mortality. But I've seen studies, not in LA County, but elsewhere, that have indicated that morbidity also has risen for heart disease and for diabetes during this pandemic period. A number of studies have shown rising rates of obesity. In one study I saw, for example, the rate of increase in obesity among children and adolescents doubled during the pandemic period. We have seen a rise in sexually transmitted infections in LA County, and actually an acceleration of what was already a rising rates of these infections. So, for example, during the first year of the pandemic, a 21% oh, I'm sorry, in the last year, not the first year of the pandemic, but just the last year of the pandemic here, it's about 21% rise in rates of syphilis, a 25% rise in congenital syphilis. This last year, we've seen 139 cases of congenital syphilis, which is a marker for I would say, a failed public health response. It's something we track as a measure of how well we're doing. It's, I think, a really alarming trend that we're seeing. 7% increase in gonorrhea over the past year. Not only an increase in drug overdose deaths, but also non-fatal overdose and higher rates of problem drug use, excessive alcohol intake. We've heard loud and clear from many parents, and in fact, many of us who work in the health department are parents, about the devastating impacts on children, both on their health, their mental health, and on their development. Studies now coming out showing the really significant impact on their academic trajectories, just the fact that they really missed in-person schooling for over a year, as well as sort of the adverse social impacts of that situation. And undoubtedly, there are going to be other morbidity impacts that become more clear as we continue to look for those impacts. So I want to just also comment on other health-related impacts. Health behaviors, as I mentioned, increased alcohol and drug use, worsening dietary practices, more junk food consumption. Interestingly, not an increase in tobacco, not an increase in prevalence of tobacco use, but increased tobacco consumption. Tobacco sales during the period of the pandemic actually increased for the first time in 20 years. Those who smoke began to smoke more heavily, but some smokers, not a large percentage, but some actually quit smoking because of concern about the effects in relation to the pandemic. Obviously, screen time increased, physical activity reduced. Obviously, the pandemic had devastating impacts on our economy, on our educational systems, on employment. Unemployment rose for a time. Now it seems to be coming back. Important implications for housing stability and social interaction, social isolation having increased during this period. And then I think in the other sessions you've had, discussion about the impacts on healthcare access. I don't want to spend a lot of time on these other impacts, but just to note that these do have health implications. The political climate was so polarizing, and I think so much misinformation being disseminated that I think that contributed to, unfortunately, less vaccination and in people not adhering to protective measures that I think would have ultimately reduced the toll that we've seen with the pandemic. Public discourse obviously is driven by, in many ways, by the political climate. I think public health institutions have really suffered during this period. I think the trust has been severely eroded. Some of it beyond our control, but I think some of it through our own missteps over the period of the pandemic. I think some of our communication has not been nearly as strong as it could have been. And then I think very interestingly, the pandemic has led really to a re-examination of public health laws, which for over 200 years were relatively stable with recognition, or the courts really giving broad deference to government public health agencies to institute whatever was needed to control disease. But some of those laws now definitely being questioned. And one study I saw last year, over 1,000 litigations now related to government imposed policies to control the pandemic. And then just impacts to our own system. Unprecedented challenges, just as everybody has been struggling. Our own staff have been struggling. We have had a substantial infusion of funding and staff. Our budget more than doubled during the pandemic, but now is beginning to decline. Much of the funding was temporary, although there have been some opportunities for more sustainable funding to support enhanced public health infrastructure. We had this very long and continue to have very long emergency response activation referred to as the incident command structure. And I think we've become much more adept at working within this structure because of all of our experience here over the last 2+ years. Major diversion of staff, about at its peak, about 2/3 of our staff were diverted from their routine duties to assist with our pandemic response. Just as in other work settings, we've had to adapt to this hybrid virtual in-person work environment. We've had a massive expansion of data infrastructure and increased data transparency. We, for example, are creating a new Office of Information Management and Data Analytics to better prepare our department to manage high volumes of data, something we were not very good at, I would say, early in the pandemic. We've had an unprecedented number of health officer orders, over 100 during the pandemic, and prior to the pandemic, it was rare that we would issue a health officer order. We've had much greater media engagement, and I think our public communications, while definitely problematic and maybe in some people's eyes continue to be problematic, I think we've made some real advances in our public communication strategies. We've had to greatly expand our direct service delivery, and I think Dr. Klossner is going to talk more about the challenges there. A greatly enhanced lab capacity in coordination with private labs to ramp up genetic sequencing, very important. Expanding surveillance now, for example, wastewater surveillance. We've had a greatly strengthened, I think, network now of community partnerships, which will benefit us moving forward. I'm going to move a little more quickly because I don't want to take up too much time. I think anybody who's followed the news knows that this is a virus that changes over time, and this figure shows how in LA County different variants have dominated the landscape. Most recently, Omicron. And Omicron continues to evolve. We now have, for example, the BA.5 subvariant that accounts for, this slide is already a little bit dated, it accounts for about 90% of the isolates that we're sequencing here in LA County. And this, I think, has important implications for how we think about the future. That even when we are in a period of relative quiet or quiescence, we can't be fully confident that things won't change. And in the case of Omicron, things changed actually very quickly last fall and early winter. I'm not going to spend a lot of time on this, but just to say that we are tracking in 8 different indicators that are viewed as early alert signals, so that if there is something new on the horizon, we'll be able to respond quickly. So the genetic sequencing we're tracking patients presenting to emergency departments. We're tracking case rates in low-income areas of the community. The wastewater surveillance I mentioned, we're tracking very closely outbreaks in skilled nursing facilities and in school settings and in settings that serve persons experiencing homelessness, and then looking at worksite clusters. We are using the CDC's framework right now, the community level framework, to sort of guide us and help us determine if we need to reinstitute certain measures if things begin to ramp up. But I will say we're not very happy with this framework. The feedback we receive from hospitals is that the threshold in relation to hospital admissions and staffed inpatient beds for the medium and high categories is too low. And so we will be, I think, rethinking this in the coming weeks. We'd like not to do this alone. We really would like to do this in concert with the state and ideally with CDC. But right now, we've not seen any new framework on the horizon, but we're hoping that there will be some new thinking on this. I did want to mention the state's California Smarter Plan. It was published in February of this year, available on the website, and I think it is a nice framework. It's about 30 pages and really charts a course and a vision, I think, for the future, recognizing that we're going to be living with this virus over years and probably decades, in fact, maybe forever. We've got to learn to live with it. We've got to figure out ways to keep people at work, keep kids in school. We fortunately have a number of tools at our disposal now. We have vaccinations, we have masks, we have therapeutics. We are working with, many different venues to improve ventilation. There will be periods when things are quiet and we can relax, but there may be times when things heat up, particularly during the winter, and where we may need to institute greater levels of protection, and we need to be able to message this more effectively with the public. I'll just, the fact was just one example of how the landscape is changing, will continue to change. Very certainly we will see, we think, the availability of Omicron-specific vaccine boosters, but there is some debate about how much benefit, incremental benefit, we're going to get with these. I think the bigger question is what will be a reasonable, schedule for booster vaccinations. The public right now, I think, is relatively confused about, when and who to, who should be getting boosters and what the timing is on it, and frankly, a lot of resistance now to further vaccination that we're going to have to overcome. So I'm going to close just with this reflection on where we've been and what this may mean for the future. I was hoping late last year that with so many people being vaccinated and so much natural immunity that we would no longer see large spikes. Each spike or surge would be more muted than the last. But with Omicron, what we saw in that high green peak there last winter was a tremendous surge. At its peak, we were seeing over 40,000 cases a day. But as you can see with the yellow line under it, which is hospital admissions, we did not see proportionately nearly as many hospital admissions as we had seen during that prior peak, the earlier winter. And in fact, even some of these hospitalizations in that later peak were what we call incidental hospitalizations, people who were hospitalized for other reasons, but just happened to test positive for COVID on admission. I think what this means in the future is that unless we see some remarkably different variant, that hopefully we'll be able to pretty effectively suppress severe illness, but we may continue to see, as new variants appear, periods of time where we have large surges in numbers of cases. And we need to be prepared and make sure that we do everything possible to get the public prepared to take further protective measures for short, defined periods of time when needed. I'll go ahead and stop there. And I'm not sure if there's time for questions now or whether we'll do questions at the end.
Well, there's a kind of a limited amount of time as we're kind of running on a tight schedule. But I'd like to ask, as moderator, one question that's been bothering me is communications or communicating with the public. It seems like we were getting words from our state, from the federal government, from the county, from our employer, from our school, from our kids' school. There's so many different sources of information. Do you see any future where there'll be a more, should we say, organized, consistent, single messaging, or is it healthcare system too complex to do that?
Yeah, it's a great point. I think, unfortunately, the problem goes far beyond the healthcare system. The countries that really did best were the ones that were unified and where everybody, or not everybody, at least, but the vast majority got behind the messaging and there was consistent messaging. But I think our country right now is so polarized that it is difficult to have consistent messaging. But I think that's the direction we want to go. You've probably seen in the news, the CDC is going to be undergoing a significant restructuring, and I think communications was, high on their list of areas that they needed to improve on. I think we're also in our department doing some reflection on ways we can improve our messaging. I think it's important as a message, is the messenger. And I think one of the advances for us has been strengthened relationships with many of our community organization partners and relying on them actually to deliver messages as more trusted sources of information within their communities. But you're absolutely right. If we cannot create more consistency in our messaging, we're going to continue to struggle.
Dr. Saluja, did you have a question?
Yeah, hi, Dr. Simon. It's great to see you. I think we've heard now that the latest public health emergency is monkeypox. And I guess I'm just wondering, what are some of the lessons that we learned from the COVID pandemic that might be translated to improve our response to this new upcoming threat?
Yeah, and I think there's been some, criticisms within the media that we made some of the same missteps with monkeypox that we did with COVID, for example, not being as quick in providing testing, not having sufficient vaccine, the messaging. I think there was concern early on that we, even though this outbreak seems to be very much concentrated in the population of men who have sex with men, there was worry about being too forward in communicating that out of concern that it might be stigmatizing, but I think we pulled way back on that. I think an important lesson has been to get out to the community very quickly. The advocates that, for example, in this case, the advocates for the gay and bisexual male population, to work with them on the messaging, and they've helped guide us a bit. I do want to just underscore, because we get a lot of questions now about monkeypox in relation to COVID and worries that now we're seeing the next pandemic. Very, very different situation. I mean, and I know everybody on the panel here knows this, and I'm assuming hopefully many in the audience know this, but it's not spreading nearly as widely, doesn't spread as easily. The mode of transmission is very, very different. It's not airborne. And we're already beginning to see a leveling. I don't want to sound too optimistic, but even in some other places, Canada, for example, I just saw some data, they're already seeing a downturn where we've been able to really, I think, vaccinate contacts and others who may be at high risk. There may be an ability to control this in the foreseeable future. Again, I don't want to be overly optimistic. I think we still have a big challenge ahead of us. We're at about 1,200 cases right now. And we're getting about 50 cases a day. The doubling time has slowed way down. We were doubling it about every 8 days. We're now down to about a doubling time of 24 days. And I'm hoping we're going to begin leveling. The state health department has actually done some modeling to suggest that the reproductive number is coming down. Still above 1, but it's coming down.
Okay, great. Thank you, Dr. Simon. Very, very interesting stuff. Wish we had more time. But we'll move on to our next speaker, who's Dr. Jeffrey Klausner, who's a clinical professor in public health and population health at USC. Dr. Klausner was a deputy health officer in San Francisco, the Department of Public Health in San Francisco, member of the faculty at the University of San Francisco, has done a lot of different research in epidemiology and disease such as the spread of HIV and STD. He's managed a number of public health programs. He was branch chief and for the Center for Disease Control in South Africa and led programs in South Africa. After returning from there, he was in the faculty at UCLA. Again, we won't hold it against him, being from USC, but he was in the Department of Epidemiology and the School of Public Health at UCLA. He's done a number of research projects for NIH and internationally. A lot of research in the area of disease prevention and control of infectious disease. He's a frequent advisor to the CDC, NIH, and the World Health Organization. Does a lot of mentoring of students and supervising of research. And he's currently a clinical professor at the Keck School of Medicine at USC. So Dr. Klausner.
Well, thank you very much, Professor Belson, for that kind introduction. Is everything looking good with my slide?
Yep.
Looks good.
Okay, great. And really happy to be joining everyone today. And it's really nice to see the different schools participating together. And that's certainly one thing that attracted me to coming to USC was opportunity for greater collaboration with different scientists and people are interested in improving health outcomes at the population level. Let me see if this is moving. Okay, so the foundations of disease control really haven't changed dramatically since they were outlined by the Surgeon General at the time, Thomas Paran, in 1937. So, about 85 years ago, he identified the strategy of finding cases through testing, notifying and tracing contacts, and treatment. Now, this paradigm was put forth for syphilis, for which there was no vaccination, but I added vaccination as a foundation because particularly for COVID-19, that's been an incredibly important and useful tool. So when public health professionals, think about, okay, how do we respond? What tools do we need? Testing, notification, treatment, and vaccines if available. And thinking about monkeypox, that's been some of the issues. Testing, notification, treatment remains a major barrier to monkeypox, and vaccination is available, but as we heard, it's really not been effectively deployed that everyone who wants a vaccine can get one. So the framework of my hopefully about 25 minute presentation was going to be to take us through these 4 different areas and see, what was done, what was really innovative, and what kind of change had to occur to respond to, certainly the, worst, most dramatic pandemic in our lifetime. So the first thing I wanted to focus was on testing, and I think most of us familiar with the early response to the COVID-19 pandemic was the substantial challenges in testing. Even though the sequence of the virus was made publicly available very early in January 2020, the United States really lagged in its ability to make testing available. So there was no available tests, really for several months, right? So the first tests were created and manufactured and distributed by the CDC. And there were a lot of regulatory issues that inhibited scale up. The FDA had to approve the CDC test, and then there were some manufacturing challenges, and that test was not as reliable as people expected. And one of the big challenges that people may not be familiar with was because the epidemic in the United States was declared a public health emergency by law that required the FDA to authorize or approve any tests that would be used to detect that pathogen. So in our current healthcare system, many of our tests that you and I receive when we go to the doctor's office are what we call laboratory developed tests, or LDTs. And those laboratory developed tests are not actually regulated by the FDA. They're regulated by CMS, Center for Medicare and Medicaid Services. They're regulated by CLIA, Clinical Laboratory Improvement Act, and states' laboratory field services. And those tests are much easier to scale and to make available. And there was a lot of concern about why particularly universities, other settings that had the testing capacity could not use that capacity to make tests available. And then, clearly there was no easy system for testing access. So, to get a test, there were very limited places early on. You had to have certain exposures to get a test. You had to be having the testing approved by the health department. And similarly, the early aspect of monkeypox testing was also limited by these requirements. And to get test results often took many days or weeks. And so the test result could not provide any real action for public health. And as people also may have heard, tests were selling for thousands of dollars each. So in Los Angeles County, Where I live on the west side, people were paying thousands of dollars for a single COVID-19 test. And it took us a really long time to scale up the testing system in the United States. Ultimately, we did develop home-based self-performed tests. And if you think about it, there's actually very few home-based self-performed tests that are available. There's pregnancy tests, there's an HIV test, there are tests for blood sugar, but really our ability to do home-based tests is actually quite restricted. So I've argued in a lot of different editorials and communications over the past 2 years that our future public health responses really require a new regulatory framework. A lot of people today study medicine and medical care. Now that's really very different than public health and public health response. And we've tried to apply medical care and medical care systems to public health. We've actually learned, and most of us who worked in public health know that those two aren't the same, and you really can't use a medical care system which is created to provide high quality care for public health challenges. So we desperately needed a new testing model. And this was an interesting example of a company that actually was advising called Curative. And this is just one example of many startups and companies that responded to the challenge to provide easy access to testing. And this is a small testing kiosk in a parking lot. And since the early phase of the epidemic, this company's provided over 30 million tests for COVID-19. So it's been a tremendous scale up and contribution to testing access. And essentially, when I spoke to the founder and CEO of the company, my vision what was to have these testing kiosks like Photomat. And, I think people of his generation, he was 24 years old at the time, never heard of Photomat, but Photomat is was an entity. It doesn't exist anymore, but it was an entity where they had these booths in shopping malls and parking lots. And it was a place you can go drop off your film and 2 days later pick up your photographs. So similarly, the idea was, could we create simple self-collected places where people could drop off a specimen and then within either hours or 24 hours get their test results back to them online. And the state of California did invest in a big testing enterprise as well. County public health departments, as we heard, partnered with a variety of different private testing organizations to be able to scale up and bring testing to people in the community. And the big question now is, okay, well, is this framework or are these models going to continue? Are we going to see testing like this for, continued public health diseases of importance like sexually transmitted infections? And, can people go to these sites, get tested for HIV, chlamydia, gonorrhea, syphilis? How about for influenza? So we're expecting to see a significant influenza season this fall. We haven't had substantial influenza activity in the past 2 seasons, but many think this season will be greater. And will there be similar, testing access, or will it be back to the old way? And I think a lot of us don't know. I mean, certainly what facilitated the massive scale up of these type of testing sites was the federal investment. So as people know through the different federal acts, the CARES Act, every test was required by health insurers to be reimbursed, and the federal government backstopped any test that would not be reimbursed. So this really opened the market. And in a market-driven economy, that was critical for the scale up of this type of testing. So I'm going to move from testing to contact tracing. So a key element of our ability to control diseases is to notify people that they have been infected or exposed. and then to elicit their contacts, and then to notify their contacts that they may have been exposed, so they can take either preventative measures to quarantine. And remember, quarantine is restricting your social movement after exposure, as opposed to isolation is restricting your social movement once infected. So if you tell someone that they've been exposed, they can quarantine, and then they can potentially reduce further transmission. And there was a big investment and lots of activity by many health departments around the country to conduct notification and contact tracing. Now, early on, we recognized that there would be, limitations in what could be done by individuals over the phone, and we launched a new program called tellyourcontacts.org. And the idea was that when someone was learning about that they tested positive, then they could go to this app or this website, and they could send a text or send an email that could be done anonymously or confidentially. And then their people within their social network who may have been exposed could be informed that someone had tested positive and they should go seek testing. We did a quick evaluation over a 2-month period in the spring, summer of 2020. And we actually found, as this was launched nationally, that there were indeed users of it, about 200 to 300 people a day, but there were importantly limitations in its scalability based on the inputs. So like anything else in our society, it has to be marketed, and marketing this site and this program required funds. And there was actually some concern from some local health departments that it was the health department's responsibility to do contact notification and tracing, and there was value to one-on-one verbal communication. And as we know, in New York City, some of the contact tracing and notification resulted in other resources for people, such as housing and places for homeless individuals or unhoused individuals to safely quarantine. And through an app like this, those services could not be provided. So there's limitations to this kind of service, but I still think it did have some utility. So around contact tracing and notification, a lot of lessons learned. And I ran contact tracing programs for HIV and syphilis and chlamydia and gonorrhea in San Francisco for about 15 years. And in the 90s and 00s, we were always understaffed and undertrained and under-resourced and had to prioritize. So when COVID hit, you had a very skeleton crew, and then you had to recruit people very quickly, try to train them and enable them to conduct notification and contact tracing. That put a huge stress on local public health programs. And I think on the flip side, the community experience with contact notification in the United States is very limited. So unless you're someone who has had syphilis or HIV or an enteric infection like Shigella, Salmonella, other foodborne diseases, or TB, which fortunately are still relatively rare on the population level, people have never been contacted by the health department to say, oh, you may have been exposed, we need to notify you. And increasingly, people don't answer their phone, and they don't respond to their email, and they throw out letters from government agencies. So, the kind of fields are not particularly fertile, if you will, for people to engage and respond to this contact notification activity. And then in our medical care system, as a physician who's practiced in public hospitals and in private hospitals, my physician colleagues are completely ignorant that they have any responsibility to notify people or partners of certain infectious diseases, which diseases are notifiable. They don't tell patients that if you test positive for Salmonella, Shigella, E. coli, the health department may contact you. It's always been a very kind of taught part of our medical school curriculum. So there's been this safety net of public health out there, but that, safety net was stretched before the COVID-19 pandemic. And then clearly these were big gaps that could not adequately respond. In places, there were some, case studies from Massachusetts and sometimes in short periods in New York City where they did find it effective. But then ultimately, as we began to appreciate that COVID was airborne and people's exposures could not be easily defined, it became increasingly difficult to really show the efficacy of notification and tracing for disease control. It became more and more helpful for case management, which is, okay, you're a positive case. Let's help you isolate. Let's get you food. Let's get you housing. Let's help you with your job. Let's provide you some resources in terms of payment. Let's get you treatment. Case management in some places became an important means for treatment, but as a disease control strategy to prevent transmission, it had a limited impact. And that's why I say the value of this tool varies by disease. It works pretty well for syphilis because syphilis has a incubation period of up to 90 days. So if you could treat someone in that 90-day window, you can prevent them from getting infected. It works reasonably well for HIV infection in some settings. It works reasonably well for tuberculosis because it's a very long chronic infection. But for something so dynamic and easily spread like COVID-19, I think it may not have worked as well as people would have hoped. So let's move from testing to contact to treatment. And treatment, in this historic analogy to syphilis, penicillin G was highly effective at disrupting the transmission of syphilis. And eventually, in end of December 2021 and early 2022, we did have FDA authorized antivirals. We actually had antiviral infusions, the monoclonal antibodies, even before that. And all those, the monoclonal antibodies, the antiviral pills, I kind of lump together as antiviral therapy that can both, prevent someone from going to the hospital and dying, and also potentially prevent the spread of infection at the population level if brought to scale. So this was a national survey that we did in January 2022. So this is about 8 months ago during that wave of Omicron, which we're experiencing somewhat unexpectedly, this large burden of infection. Fortunately, a little bit less linked to hospitalizations and death, but it was definitely a serious period during the epidemic. We surveyed over 7,000 individuals who had positive COVID-19 tests, and a little under a quarter reported that they sought treatment or medical advice for their COVID-19 diagnosis. So only about a quarter of people with a positive test actually acted on that test to seek medical advice. And then of those quarter, less than 10% actually received any antiviral therapy, which was a monoclonal, nirmatrelvir, which is Paxlovid, remdesivir, which was given IV, but could be given as an outpatient, or molnupiravir, which is the other antiviral pill. So that's about 2.5% of the entire positive tested population in that time sought antiviral therapy. And, seeing that, I thought that was a big gap in our public health response. And I was, thinking about how can we try to close that gap. So we worked with the large testing company to create a partnership with essentially an online pharmacy called TruePill. TruePill is more than a pharmacy. TruePill also does telehealth and other kind of kind of behind the scene digital health services. But the idea was everyone who gets a positive test then gets like a free linkage to TruePill, where they could get a telehealth visit and then, seamlessly, if they're eligible based on the fairly strict eligibility criteria of age or comorbid conditions, get prescribed antiviral therapy that then would be mailed to their house. So the beauty, and one of the I think the big positives out of the COVID-19 pandemic has been this digital health revolution of the idea that people can engage with the healthcare system through telehealth, get medications mailed to them, and never have to suffer the burdens of traffic and waiting and delays to access timely treatment. So we did a review of this partnership, and we found, and this was about the spring to summer, so it's about April to early July 2022, so really relatively recent information. We see about 20 to 50 people a day are getting treated through this partnership. And I don't have the denominator, I'm not showing you the denominator here, but this is about, instead of 2.5%, we're up to about 25%. So that's a substantial increase in the proportion of people with a positive test who are eligible for treatment, getting treatment. And this is just one, example in one partnership. And unfortunately, this was never replicated or scaled across the system with other major testing laboratories and commercial testing sites. It does fit into Biden's kind of test to treat initiative, and people may be aware of that, where through that treatment became more available at commercial pharmacies. There were websites to direct people to pharmacies which had treatment available. Pharmacists were authorized to prescribe treatment based on a certain protocol. But I would also argue that in an emergency, we need to go above and beyond our medical care systems. And in an emergency, my question is, which is worthy of debate, shouldn't medications be over the counter? So we're dealing with an emergency. By definition, the house is on fire. So we need to do things differently than the way we respond to, traditional medical issues. So some lessons learned on treatment was that neither the medical care or public health system was prepared to deliver treatment in a timely fashion or to scale. As I just mentioned, medications are countermeasures in a public health emergency. We need to deploy them differently. The medical care system depends on public health programs to notify patients who are positive, to get them treated. Even today, a lot of my medical colleagues may diagnose someone with positive test result, and they themselves or their clinic will not take the additional steps to make sure people get treated in a timely fashion. So we need new paradigms for treatment delivery. So lastly, I wanted to cover vaccination, because we've seen a tremendous kind of shift in how vaccines are delivered and deployed in the United States. And in the fall of 2020, and this was before any COVID vaccine was authorized, we did a small demonstration project with influenza vaccine. So we were, supporting and staffing these very large COVID testing sites at places like Dodger Stadium. And we asked the question, okay, if we offer influenza vaccine at Dodger Stadium, will people accept influenza vaccine? And can we do that in the context of all the, existing regulations and training and documentation and bureaucracy that's required to meet, current medical standards? And the, short answer was yes. In a, very brief amount of time, we were able to, deliver 600 influenza vaccines in a week. And, this was a, substantial finding that I think set the framework for others to then build on and, start deployment at these, major vaccination sites. So many of our, sports arenas around the country were scaled up to provide vaccination. That's Dodger Stadium in the upper left. You had community-based groups, VFW sites doing walk-in for vaccination. And then you had mobile services going to communities in rural communities, mobile vans going to farm workers groups. And, this was dramatically different. So some lessons learned, and I think I'm wrapping up soon, is that, neither the medical care or public health system was prepared to develop vaccination in a timely fashion or to scale, not very different than a lesson from the medications. Vaccines, again, are countermeasures. I think they were more readily seen as countermeasures, which meant, medical students, pharmacy students, other health students could be deployed to give vaccinations. It became much simpler. Now, obviously, the implementation into local pharmacies has made it much more sustainable. However, we still have a big gap in integration of vaccination and registries and our medical care data systems. And folks from Harvard have been writing about that more urgently, that, people go in to see a doctor, the doctor's medical records are not linked with their state registry. Some are, some aren't. It's a big gap. I think all of us as individuals know how difficult it is to obtain your vaccination records. If you want to send your child to camp, how do you get those records? If you want to send your child to school, how do you get those records? You have to go to the pediatrician. Very complex. It's antiquated in my humble opinion. So I'll open it up now for Q&A. Thank you.
Very, very interesting. It's a complicated world, but I think in order to cover all the guest speakers we have here today, I think we better go to the next presenter, which is Dr. We'll have some time for questions at the end, but Dr. Klausner, thank you very much. It was really fascinating. Our next speaker is Dr. Howard Hu, who's a physician as well as a scientist, internist, researcher, specializing in preventive medicine. He has a doctorate degree in epidemiology. He's been a professor of occupational environmental medicine, a director, founding director at NIH Center for Children's Environmental Health, a physician and working at the Harvard School of Medicine, and a physician at Brigham and Women's Hospital in Boston. He's done a lot of research in various organizations, including Michigan Healthcare System. He also was a visiting scholar at my alma mater, the University of Washington, where he was an affiliate professor in the University of Washington School of Public Health. Since 1990, he's been involved in a number of research programs, advising students and area of infectious disease and child development and aging, a number of areas, worked internationally with US, Mexico, India, China, and elsewhere in the world. Recipient of a number of achievement awards, Linus Pauling Lifetime Achievement Award, 2011 Award of Excellence from the American Public Health Association, and the 2015 John Goldsmith Award. Obviously impressive background. Also, since 2020, he's the chair of preventive medicine at the Keck School of Medicine at USC. So, Dr. Hu, you're on next.
Thank you very much for the invitation to come, Dr. Belson, and thanks for advancing the slides, Alyssa. First, I have to say that you have just heard from the two giants in addressing the pandemic here in Los Angeles County, someone who represents the LA County Department of Public Health's response, which has had, in my view, has been magnificent, leading the nation in terms of using evidence to dictate policy, and Klausner, who's been leading in the trenches, at the front lines of how you deal with this pandemic in terms of testing, treatment, vaccination, and also the important role of private industry in partnering in the response. So my perspective is going to be a little bit different. It'll also be shorter. I'm going to talk about how this is addressed by a Department of Population and Public Health And I myself, the one thing that that was wrong about your introduction, Dr. Belson, is that I am not an infectious disease specialist. In fact, I'm mostly environmental health, epidemiology, internal medicine. But in fact, so many of our faculty pivoted to work on COVID-19 because, in fact, not only was it once in a lifetime pandemic, but we're living it ourselves. Next slide, please. Just one slide to brag about the department. Is about 120 faculty, 32 postdocs, over 1,000 students. It's the #2 department in the country in terms of NIH funding. And it's a full service department addressing all aspects of population and public health. Next slide. By September of 2020, the department had formed a center for pandemic research. And this center was a place where our faculty could turn to for various resources in trying to mount a research responses that would provide evidence for practical public health responses to the pandemic, leveraging some of their own research, some of their own epidemiologic cohorts where they've already been collecting data and samples for many years. Next slide. Among the attributes of the center was a survey working group that quickly used the many different types of survey instruments that are being compiled by the NIH on one of its data repositories of instruments to be used for COVID research, and providing them to investigators as different survey formats and designs. Next slide. Our data sciences working group, led by David Conti, provided the statistical tools for visual mapping of the data, including data that was being produced by the LA County, but also our own constituency from their various cohorts. Next slide. A laboratory working group run by Andrea Kovacs had worked with industry partners to develop the best antibody testing tools that could then be directed towards the various cohort and cross-sectional studies that were being conducted by faculty. Next slide. And just to give you an example of some of the research that the center was mostly involved in, this was the LA cohort pandemic surveillance study. That's a partnership with Paul Simon and colleagues at the LA County Department of Public Health. This study, led by Neeraj Sood, who's one of our faculty, but primarily based in the Price School and the Schaefer School and the Schaefer Center, was a study of the seroprevalence of antibodies that tried to take advantage of the cohort design, which was all about finding a representative sample of adults representing different geographic regions of LA County, different ethnicities in LA County, different age groups. And what we found, perhaps not surprising, given everything you've heard today, that the rates of potential protective immunity that we can see based on the antibody was much lower for Black individuals and those from lower income households, and the much higher cumulative incidence of infection in the high poverty areas that we could see in this cohort surveillance were certainly among the factors that probably contributed to the steep socioeconomic disparities that Paul described in mortality rates observed in LA County. Next slide. Here's an example of another study that was based in the Pandemic Research Center. This is a study actually of ourselves, of USC faculty, staff, and students, funded by the Keck COVID Research Fund and the USC Provost's Office and Vice President for Research. And here we're doing sequential surveys of attitudes towards vaccinations, to masking, to other protective measures. And among the findings were low vaccination rates. Interestingly, in our population of Asians, Latinx, and multicultural staff and faculty in relation to white faculty. Staff in general had lower vaccination rates than faculty, and this is about midway in the spring of 2021 is what the survey reflects. The folks who are essential workers, ironically, had lower vaccination rates, and Republicans and independents, and you've probably seen this in much of your reading of the national news, had substantially lower vaccination rates than those who identified themselves as Democrats. Next slide. Then in a study of vaccine attitudes towards boosters among students and staff, what was striking was higher willingness to have boosters among Asians than other ethnic categories, but by far the most compelling determinant was trust in science, the degree to which you trusted science in general. Next slide. And here, paralleling the same kinds of results that are seen in the general population, we could see that even among our own students, there was less trust in science among Blacks that ran across both in terms of trust in science and also willingness to have boosters. And clearly there's a messaging and communication need in our own community, so we can compel our community to take the needful steps in order to protect themselves from the virus. Next slide. Then as an example of some of the research that our community does, pivoting to add COVID-19 to some of the ongoing research that we have. This is an example of a study, a long-term study being done on air pollution impacts in California, which showed that actually the combination of air pollution and also COVID-19 was giving you much higher mortality rates, suggesting a degree of synergy, which is surprising on some level, given what we know about the impacts of air pollution on lung immunologic responses and susceptibility to infection. Next slide. And here's where some of our work also intersects with actual translational science and trying to actually move the needle in communities. This is the community engagement group of the Pandemic Research Center led by Lourdes Visconti Garbinati, which undertook this far-reaching campaign in LA County to partner with various groups within the university to produce communication tools that can be used to increase vaccination rates. Next slide. This included social media messaging campaigns that reached an estimated of 1.9 million residents. Next slide. And 2 short 8-minute videos that are just fantastic. You should see them if you haven't seen them at the website www.vaccinatela.info. We involved the acting community, our movie production faculty, and these films, which are truly entertaining as well as informative, and now been adopted by the Biden administration. They were tailored for the Latinx community as well as the African American community, and now they're being distributed and used all around the country. Next slide. Oh, you can go to the next slide. And finally, they've done the research to show that the vaccination rates in the communities that were targeted for these strategies seem to go up substantially, providing evidence for this intervention, and that underpins our commitment to doing public health research that's translational and that actually gets implemented and moves the needle. That's implementation science at work. Next slide. So what was mentioned earlier today was that even though we're in this period where we're anxious, we're looking at what new variants will come up. We're gratified that the mortality rates seem to be low, even though we're having fairly substantial infection rates with the BA.5 variant, probably due to the combination of natural immunity as well as vaccine and booster related immunity. We are really concerned about this growing phenomenon of long COVID, with an estimated 23 million Americans potentially having symptoms that last for more than 3 months, more than 6 months, affecting the average American's ability to work, and the full magnitude of the health and economic effects are not known. We don't understand what causes long COVID, and the condition raises all sorts of policy questions. Next slide. We have started an initiative to do research in this area. Part of it is directed at the most salient manifestations of long COVID, which are arguably neurologic, cognitive impairments, headache or fatigue, dysautonomia, the cognitive impairments often described as brain fog, and inability to think straight. This has all been documented in a number of different surveys that have been published recently. Next slide. And there's been a whole host of theories that have been developed, still to be tested, regarding the role of chronic inflammation, immune dysregulation, mitochondrial dysfunction, microvascular thrombosis, perhaps even persistent viremia from pockets of viruses that persist in the body. All of these need to be tested in rigorous research so we can come up with better strategies for management and possibly even therapeutics. Next slide. So our next step in this Pandemic Research Center is to work on an initiative to address what's now known as NeuroPASC or neuro post-acute SARS-CoV-2 syndrome, leveraging some of the USC-based strengths in our multi-ethnic cohorts with archived biological samples and phenotyping, and the expertise that we have in inflammation, immunology, mitochondrial function, neuroimaging, and data science. And hopefully we can shed light on some of these mechanistic pathways and potential therapies in the coming years ahead. Next slide. That's it from me.
Okay, great. Thank you, Dr. Hu. I think what we'll do is, since we have a number of speakers here, is to kind of move on to the next speaker, and then we'll do questions at the end. So I'd like to go to Dr. Watanabe, who I don't believe has slides, but would like to talk to us about his work and knowledge in this area. Excuse me. Dr. Watanabe is professor of population and public health at USC. He's Associate Dean of Health and Population Sciences Program at the Keck School of Medicine. He has his PhD at USC. He was at the University of Michigan School of Public Health, has done a lot of work in statistical genetics at Michigan. He was in the research faculty, is a member of the USC faculty of Population and Public Health. I've done a number of research projects in diabetes, obesity, other disease areas, developing mathematical models related to that. He teaches undergraduate and graduate programs at USC, vice chair of for education. He's done a number of projects for NIH and in biostatistical educational summer program, and very knowledgeable in this area of public health. So let me pass the baton on to you, Dr. Watanabe, about what's been the impact of and what we've learned from the COVID pandemic.
Thank you, Dr. Belson, and thank you to all the previous speakers, because I think they all hit very important highlights that I just want to briefly talk about. And I'm sure some of you are thinking, why is a person who studies type 2 diabetes and obesity being asked to be on this panel? But in addition to my research, part of my job has been in the education area, and I've, for the past 12 years or so, have taught in the undergraduate program a course on epidemics and their causes. So when the pandemic started, you can almost imagine my sort of dread and also my delight in that I started teaching this class in the spring semester, right when we were starting the pandemic here in the epidemic here in the United States. And basically my students had a front row seat to what an epidemic is, what a pandemic is, and the response, and all the things, all the theoretical things that we were talking about in class, they would actually get to see. And one of the things I did in that spring was right before we transitioned into online teaching, I had told the students that they were going to see a change in the American public, that this health crisis was going to bring Americans together, and that we would all work together to fight this pandemic and try to make it through. And then about 3 weeks later, I went into class and I started class by saying, boy, was I wrong. And it made me realize that in terms of teaching public health, there were several deficiencies that existed and that we needed to address. And I think we need to be thinking about how to change our public health education, both for public health professionals, but also for the public. And one of the immediate things that I noticed was, for example, in the media, everyone considers the front line in the pandemic to be the clinic or the hospital or the physician office, when in fact the front line is in your public health departments, your public health officials being out there trying to prevent infection, trying to prevent spread, et cetera. And I think this is where public health is extremely underappreciated, the role that public health plays in overall health. When the public hears health, they immediately think of their physician. And of course, that's not to minimize the role of healthcare professionals. They were putting their lives on the line very early in the pandemic when we didn't know very much. They were running long shifts. Many of these people were exhausted and mentally stressed because of the things that they had to do to respond. But at the same time, I think people underappreciate that public health officials like Dr. Simon were working equally as hard to try to protect the public from this virus. And in fact, one of the things I kept reminding the students is that, the virus doesn't care about the things that divide humans, right? All it cares about is reproducing, and you're just happy you happen to be the perfect host for them to do that. But all the things that divide humans, whether it's religion, politics, sexual orientation, whatever it is, the virus cares less about that. And so when it comes to responding to these things, we as well should care less about that and try to focus on the right things. Yet as humans, we let these things sort of drive some of our thinking. And so all these things that were discussed earlier, I think, are things we need to incorporate into our public health education for the next generation of public health officials and professionals, so that they can have the right tools to be responding to, the next thing. Unfortunately, the next thing came pretty quickly with monkeypox, but there'll be another COVID-like thing in the future. And we need to be prepared to respond to that. And, one other area that I think is very important, and that, Dr. Klausner pointed out, is that as public health departments and other public health entities are always ill prepared for large crises. And that's because of sort of the, lack of recognition that public health departments get, and therefore the resources are not circulated to them. And so we need to be thinking about changes in the way we operate public health departments. One idea that a few of my colleagues and I were discussing is whether we should be considering like a public health reserve. The Army has a reserve, right? Soldiers that were initially trained, they're not on the front line doing anything. They go in, you know, a weekend or so to get refreshers, and then they're called up when they're needed. And having something like that for public health, where we have public health emergencies and suddenly need contact tracers, you know, and other, you know, professionals to help meet the data needs and the screening needs and all those other needs that we have during a pandemic is very important. So again, I think all of these things we need to be teaching our next set of public health professionals, but at the same time, we need to be teaching the public. And this is where I think public health has been weakest, in my opinion, in sort of messaging and getting the public to understand the complexities in a way that's you know, easily digestible for them. And you know, the media and information dissemination has gotten more and more complex. You know, with social media, people now get to pick and choose what they want to listen to. I remind students that, you know, I'm old enough to say that when I was their age, you know, we had 3 national TV stations with 3 news outlets that essentially disseminated the same information with slight differences. But they were basically sending out the same message about the news. There was no talking head interjecting opinion, right? All the opinion shows were separate, usually on the weekends. Now with the news, you don't know what the difference between the news and opinion and, you know, anything else is, because it's all sort of mixed together. And then if you don't want to listen to those guys, you can go online and pick whatever medium you want, and you can listen to people, like-minded people, and, you know, you don't listen to whatever else is going on. And so I think this is a huge challenge for public health in terms of how we educate the public so that they understand the value of wearing a mask, the value of getting vaccinated, rather than saying, oh, well, you know, there's a chip in the vaccine, I don't want to get chipped. You know, I usually tell people that say that, well, I'm sorry to tell you this, but you're not important enough for us to chip if we were chipping people. So I think that's another big challenge that we have. And I think that's also something that we need to incorporate into our public health education system, to get public health professionals to understand how these things work, how to leverage these things for themselves. I'm part of that generation that still can't figure out how to use Twitter or, you know, Instagram or any of these other things young people use. I try, but I know I'm not being as successful as I probably can be. But, you know, that's sort of the wave of the future, right? And I mean, in 10 years from now, it won't be Instagram, it'll be something else. But we need to be able to leverage those technologies to disseminate information to the public so that they're just as informed as the rest of us. And so between that and also appreciating the ever increasing role of politics and the lack of political leadership is something that we need to be thinking more about and again, incorporating into our education of our public health professionals, because I think this has been the first time that at least I'm aware where public elected officials have basically decided that they don't need to lead and that their own individual opinions about what's going on is more important. And it costs lives. At the end of the day, bottom line, it costs lives. And that's something that we shouldn't be tolerating. And so trying to understand how public health and politics interfaces and how we as public health officials can help, you know, manage that or move that needle in the direction that we need to move it in, I think is just as critical as any of the other things that we do in the public health realm. And with that, I'll try to keep it short because I think that there might be a need for a very robust Q&A and discussion, and I'd like to leave time for that. So.
Okay, great. Thank you, Dr. Watanabe. Really interesting. Yeah, we got a bunch of questions, and let me lead off with one that actually, we did a similar program last year about learning from the pandemic, and one of the speakers actually has a rather high-profile position in healthcare in Los Angeles, said, someone asked about the CDC, and he said, well, the CDC is a political organization and therefore is limited in its role. What role should, does, could, and I guess I'm asking this of all the speakers, should the CDC be the preeminent dispenser of information, as Dr. Watanabe was just talking about? What is their role? Any of the speakers, I guess, could speak to that.
I can start. I'd be really curious to hear what Jeff thinks, because both of us have experience. I was with the CDC for 8 years. And it has become a political organization in the sense that the director is a political appointee. Prior to the mid-'80s, it was not a political appointed position. It really, the selection was made independent of elected officials, and generally it was someone who had a really long history of leadership in public health, often with CDC. And Jeff, I'm thinking about Bill Foege. I think he was the last director that was not a political appointee. Not to say that the more recent leaders have not been good, but there has definitely been an increasing level of political influence, and that really accelerated, I think, during the pandemic. And I think there have been some discussions about how CDC could be better sort of protected from that political, influence. And I think, sadly, CDC lost a lot of great leadership. There has been a lot of frustration and some really outstanding folks that have left, either retired early or moved on to different kinds of positions. But overall, I have to say I have tremendous respect for the CDC. I think there definitely were some bad missteps in their handling of the pandemic. But overall, given, thinking about the history of the CDC dating back to the late 1940s, I think it's really been an amazing institution, and I would hate to see us abandon it in its leadership role in public health in this country.
Jeff or Richard?
Yeah, so I mean, I think, the CDC 75 years organization, I mean, until this pandemic, I mean, that was seen as the, go-to organizations for guidelines and, recommendations. I mean, they were slow, they were methodical, they were evidence-based, they, understood the population health over individual health, and under Mr. Trump, it became an unusual response in organization, and that was, unprecedented. And the question is, how do we depoliticize it? And one way is to not have a, politically appointed director, and the other way is to, kind of try to recreate that, culture of that we're not, political, we are public health scientists, and that's still an important role in terms of communication leadership it can play. I think people did have like false expectations that CDC was like an operations and deployment and service organization. And while there actually is a reserve of U.S. public health officers that were called up and have been called up occasionally for different activities, it's an organization of scientists and researchers, and researching public health and trying to come up with the best guidance they had, not in terms of deployment and services. So I think moving forward, which is what they did in the UK, right? They have a health security agency. They kind of redid their whole public health administration organization, and that's what we really need to figure out how to do.
Yeah, I would think, regardless of the issues about politicization of the CDC, I still think we need a central organization to be the megaphone, putting out the messages, with the rest of us, supporting, messages as needed. If you have different entities giving out, the lack of coordination of messaging would just be disastrous. If everyone's spitting out different opinions or different edicts about what should or shouldn't be done.
Yeah, you know, and that, I mean, that's CDC historically recognizes that. And they always had like phone calls with health officers, you know, in advance to, you know, kind of process everything and get everyone, you know, singing the same song. I think, you know, we were missing that leadership early on in the, pandemic from CDC, and they were, you know, handcuffed and put in, feet in cement blocks in terms of they could not actuate their normal response for different reasons. And, you know, that created this mess.
Sonali, did you?
Yeah, I have a question, and thanks for those comments. I think the CDC is doing a bit of a reckoning right now and restructuring. But I have a question, Dr. Hu, for you. That was a great presentation. So much impressive work that your department has been doing. I'm working with some faculty from your department, and we are trying to kind of take some messaging about vaccine promotion into the community with community orgs and care managers, trying to increase vaccination rates for medically fragile, low-income populations, and we're really struggling with it. And we're wondering if we're kind of hitting a plateau with folks that are unvaccinated really being incredibly hesitant at this point, and whether it's worth continuing to pursue vaccination in this population, or maybe saying, well, we need to maybe move on and divert energy elsewhere. What are your thoughts?
Yeah, that sounds like a practical question, balancing the difficulty and the stress of trying to get this message through to folks who sometimes are actually not only reluctant, but they're antagonistic to vaccination. I think that as long as we have used all of our informational tools to get the message across, including the use of popular celebrities, friends and family, there's not much else we can do. And that's where often some of the debates lies, sort of the balance between civil liberties and what constitutes the public health dictum. What was really interesting was an editorial that was written by the leaders of the American Civil Liberties Union some time ago that was in the middle of the pandemic, addressing this question of, whether the masking mandates and other mandates were affecting civil liberties. And their whole point is that, in fact, not masking and not following public health mandates, in fact, infringes on the civil liberties of everybody else. And in the balance of things, this is what public health has to deal with. And that's an argument that is a social and policy-wide argument. But when it comes down to individual people, of course, people still have free choice.
Well, as a layman, as I understand it, the unvaccinated people become a threat to us all. Is there a point where should consider economic incentives, payment for people to get vaccinated, or enforcement of some sort? Perhaps other countries have a better solution.
It's a great question. I'd love to hear Paul's view on that. I think economic incentives would be the most likely incentive that would move the needle. But I don't know. What do you think, Paul?
Actually, we did we implemented a program with the homeless population where we used a financial incentive, and it actually worked very well. There were some real ethical concerns about it, though.
Sure.
But I think with input from the community, everybody felt comfortable moving forward. But I think in the general population, the economic incentives haven't worked as well as we thought they might. But we have mandates. I mean, for kids that go to public school, they must be vaccinated or Otherwise, there are alternatives for them. And there was a period where we were pushing, vaccine mandates for the workplace, but there's just so much opposition right now. And our biggest worry is that this sort of anti-vax sentiment is generalizing now beyond the COVID vaccine to the other more routine vaccinations that were more widely accepted prior to the pandemic. So I'm
Holy
not sure what
moly.
the right answer is. Yeah.
No, that's really.
Yeah, I mean, there were lotteries in Ohio. I mean, there was, requirements for workplace, right? There were, vaccination requirements to enter venues and certain events. What I think was missing and which caused pushback, honestly, was the public health did not recognize the equal, benefit of natural immunity and recovery from infection. So, people are smarter than we often want to think they are. And they knew they had equal protection if they recovered as if they got vaccinated, but public health said, no, you have to get vaccinated anyway. And that, was a reason people generated a lot of pushback, which went beyond the microchips and, sterilization fears. I mean, there was just this kind of, why do I have to get vaccinated if I've been recovered? Doesn't make sense.
Kind of a question for all of you in public health. So has the COVID-19 pandemic created a more knowledgeable public so that we'll be better off for the next one, or is it worse?
It's a great question.
I don't know, but I think over the course of the pandemic, I was contacted by PolitiFact maybe about a couple dozen times to help them, fact check certain things that they've identified, and just based on that sampling, which I realize is totally not a random sample, but no.
Well, it seems to me that you public health folks have learned a lot. Sonali, do you have any other questions?
Yeah, actually, I was wondering, Dr. Klausner, you kind of commented on a lot of the communication challenges that are occurring, not just with COVID, but with all, many reportable diseases not being reported. And we have this whole thing now where people can test at home, but there's really no way to communicate those findings. So I'm wondering what your thoughts are on that, and also others in the panel. And I also, I receive a text every week asking, how am I feeling? I don't know how I got this signed up for this. Maybe you guys get it too. Is that something that we think is effective, like this weekly surveillance where we're just trying to reach people and check in? What are your thoughts?
So the first thought on the, absence of reporting of the home test, I think that's okay. I mean, there's actually multiple ways that we do surveillance. So one is by case reporting, one is what we call prevalence monitoring. So what's the positivity of everyone who's tested when they come in the hospital? The other one are, population-based studies like door-to-door studies and, recruiting people, looking over leftover blood specimens from other tests. So, we could always do that better and more often, but those are, costly and do take a lot of effort. So having one small absence in one of our pillars of surveillance, I don't think is that critical. LA County, maybe Paul can speak to this, it does have this like symptom survey, and every week they report on their weekly report the proportion of people who report upper respiratory symptoms. And people like me actually follow that, and we find that interesting. Maybe you're part of that. Maybe you're part of the VAERS vaccine adverse event report system. You signed up when you got vaccinated, and maybe it continued. I'm not sure.
Yeah, Sonali, I'm fairly sure you're part of this, what Jeff mentioned first, this initiative we have. It's called Angelenos in Action. And
That's the one, yep.
Yeah, yeah.
what I-
And so we so appreciate your participation. It's a very kind of crude measure, but the trends really align well with our other metrics, the other sources of surveillance information. So I do agree with Jeff, though. I think we have a number of different sources of information. Most recently, the wastewater virus concentrations that can be helpful in monitoring trends. So I think the importance of increasing access to testing outweighs the loss of that source of information for surveillance.
Right.
Sonali, another question?
No, go ahead, David.
Well, I think this has been really fascinating. If in some cases depressing, but certainly fascinating. As an engineer, there's a lot of engineering probably. My smartwatch does a lot. Is my smartwatch ever going to test? Or are there technological solutions on the distant horizon? In terms of public health and managing disease like we're talking about here?
Big data, maybe one day, right?
Well, for certain things, definitely. I mean, in the diabetes field where people are actually testing smartwatch-based glucose monitoring, we already have implantable glucose sensors that are used. It's not going to take that long to shrink those down to something that'll fit inside your smartwatch.
I'm sure there's some engineers at Apple who are working on this right now.
Yeah.
Trying to figure it out.
They measure temperature now and oxygen level, who knows? Well, okay, anyway, this has been really fascinating. I'd like to thank everybody's participation, very informative. Alyssa, do we have any wrap-up steps? But thank you for participating. We've recorded this. It will be available. We'll send you links to the recording if you want to share it with others. And sincerely appreciate everybody's participation. So
Thanks so much.
That'll
All
do
right,
it.
thank you all.
Yeah, thank you.
Thanks.
Thanks for
Bye-bye.
organizing this.
Bye.
All right.
Bye.
Bye.